người ta hay bị ghi nhận bóng đá Ilova Wasa Ba Lan. The next speaker, Dr. Thomas Jagielski, who received a dental degree from Medical University in Warsaw, Poland in 2014, and he's received his PhD degree from Medical University in Warsaw in 2019. And he's now the specialist in periodontics and from Infant Jesus Clinic Hospital in Warsaw in 2020. And he's practiced his own clinic at Innova Dental Clinic in Warsaw. So welcome, Doctor.
All right. So, good morning, everyone. My name is Tomasz Kaczyński. I'm a periodontist and I practice in Warsaw. So it's a real honor and pleasure for me to be here with you today. So I'd like to thank you for the invitation. So as a periodontist, I would like to present to you the contemporary approaches to immediate single tooth replacement in the aesthetic zone. So as you know, our patients that need the single tooth replacement are usually the younger from the group of our patients. So they usually have very high expectations, and they usually also require quite short treatment period. So let's say this patient shows in your office. This is a trauma patient. It's a young patient that her central incisor was indicated for extraction. And as you can see, there are some risk factors that should be considered. First of all, as you can see, she has a very high smile line. She has a thin gingival phenotype with, highly scalloped papillae, high papillae, this triangular shaped teeth. And what's another thing to consider is that her zenith levels are not equal. So we should consider two possible treatment options. One is the delayed approach. That means, we extract the tooth, wait some period for a socket healing, and after that we replace the implant. Maybe we need some another procedures that's usually required to do some either soft or hard tissue augmentation, or we can consider, tooth extraction and immediate implant placement with hopefully immediate provisionalization. So when you choose proper treatment options, the thing we should focus on in the aesthetic area is first and foremost the aesthetics. The anterior zone is not very forget the patients. They will not forgive us if it's not perfect. With my patients, we want the treatment modality that is predictable. We want predictability in all of our treatment therapy, but it is especially crucial when we are dealing with the aesthetic zone because, the failures in this area can be especially challenging. And of course, time efficiency. As I said before, many patients that require just single tooth replacement are usually quite young. They have a quite active social and work life, and they are not able to function without anterior tooth. So when you want to get really good aesthetic outcome in the exterior and the anterior zone, you should consider two aesthetics. First is the white aesthetics, which is, let's say, more depends on our technician, not actually on us. And a pink aesthetic, which is completely dependent on us. It's not dependent on the technician. It's about how we manage the soft tissue, how we manage the implant position, how we manage temporal restoration. And once we can get perfect harmony between white and pink aesthetics, we can expect the result, like the final outcome, to be aesthetic. So to meet our patient high expectations, as I said before, crown is something that's mostly like done by our technicians. So it's not really something that's dependent on us. So our most important as a dentist factor is actually the soft tissue. To get really good aesthetic outcome, we need good soft tissue contour. We need the papillae. They have to be symmetric to the contralateral side, and we also need a special tissue volume, tissue bulk. So that is in order to mimic the root, the root on the adjacent tooth, as well as to to cover all the colors of the prosthetic components. So, as you know, the implant integration is no longer a success. This implant is integrated. It's been functioning for quite some time, more than 10 years, but is it successful? Well, it depends if you're lucky and your patient has a very low smile line. Actually, it's this particular patient. She came for the implant in the mandible, so she didn't really mind this because she had like a very very low smile line. But do you want to our result to be dependent on the luck, or we want to to control it? So for me, I'm never lucky. So I never trying to I'm never trying to go into compromises in the aesthetic zone. Or this implant also, it's integrated, but is it successful? No, same here. Maybe it's not terrible, but we see the tissue volume is a big problem. So if it's in a high smile patient, it may be really not very aesthetic. Okay, treatment time. So this obviously the biggest difference between the immediate and delayed approach. So when we are considering the immediate implant placement, usually we are doing extraction, we do immediate implant placement, we do immediate provisionization. We also do extra surgery to accommodate like a soft tissue grafting or bone grafting to get to that later with details. And if we are able to do that in the single appointment, we usually, finalize our case after 4 months. So it's very efficient in terms of time. So considering the delayed implant placement, so there are like really, really many options. This would present you with the most the longest time possible. However, most cases are shorter than this. So if we are going for delayed implant placement, usually we extract the tooth. We can wait, some time either for bone healing or just for soft tissue healing. But let's say on average that would be about 3 months. Then, if it's necessary, it might not be a case for every patient, but if that's necessary, we may need to perform some, bone regeneration procedures that might take also approximately 4 to 9 months. So let's say 6, depends on the technique and on the whether it's like the vertical or horizontal bone defect. Then we going for the implant placement. Usually, at least for me, when I do some bone regeneration, guided bone regeneration, I don't immediately load this implant so that, wait for healing, we do exposure, then need to do provisional restoration and to shape the soft tissue where provisional restoration. So, probably this is like the most like pessimistic scenario. It won't happen like this in like most of the patients, but in theory, it could take up to 21 months. So it's like definitely it could be longer. So we know it's faster, but the question is, if it's faster, is it better the immediate implant placement? So when we look into the studies, this is like quite recent randomized clinical trial that was conducted by the group from Vilnius with Alvydas Poisis and Thomas Minkevicius. So they compared the clinical outcomes for the immediate and delayed implant placement, and they found that there were no differences in aesthetic and clinical results. They found optimal aesthetics with both treatment modalities, and they assessed this with it's called the pink aesthetic score. It's kind of like a objective way to measure aesthetics. As you know, the aesthetics is very subjective. What I might find aesthetic may not be appealing to you. And what's the most important, the immediate implant placement required half both the chair time, so that means how long the patient spent in the dental chair, and the overall treatment time. So it was 2 hours versus approximately 4 hours, and it was like 4 months versus approximately 8 months. As you can see, with immediate shrunk placement, you're able to reduce both of the chair and treatment time. So of course, it's always a good idea to not to make any conclusions, definite conclusions on a single study. So it's always good to also check with the most recent systematic reviews and meta-analysis. And this is the one that included 16 studies about approximately 1,000 patients and more than 1,000 implants. And what they concluded in the study was there were no significant differences between immediate and delayed dental implants. So immediate procedure showed a lower incidence of bone loss in single implants. So immediate loading of dental implants is a successful treatment process and is effective in reducing treatment time. So as we know, if some specific criteria are met, this can be very successful treatment option. So to sum up, the immediate implant placement can be related to less bone loss, less morbidity. It can be most cost effective because it's less time, less procedures. There's it's also the very good provisionalization. So usually, the patients they never love any kind of removable provisional. So if it's like directly screwed to the implant, it's also the best kind of provisional we can offer our patient. So let's back to our patient that I showed you before. So in this particular case, I extracted the tooth, I performed immediate implant placement, and we also did immediate provisional restoration that was screwed to the implant. And in only 4 months, and remember, I already told you it was, challenging case. We got results like that. So it is perfect. Probably, we are dentists. We can always spot implant. But for most of the patients, this result would be considered as pretty aesthetic. So considering short treatment time and reduced to only 4 months, we can really, I think we all agree, it's not that bad. Personally, I'm not sure I could achieve better result doing delay. So we know daily implants can work, but there is definitely more to that before we draw any conclusion. So there are different factors that can affect, the diagnosis, the success criteria, and the prognosis of our treatment. So I would like to go with more details into that. So the first thing is the bone remodeling. We all know that from the socket healing biology that once we extract the tooth, we initiate some processes. So what's the most important is on the buccal side of our tooth, we have a bundle bone. And the bundle bone is like very thin bone that is gets most nutrition from the periodontal ligament. So once we extract a tooth, it's usually gone unless very thick in a thick phenotype patients. Usually it gets resorbed. So it's not our topic. I'm not going into that, but that's one of the reasons why the socket shield technique is maybe it's a difficult technique, but maybe one of the most biological techniques to preserve the contour of a ridge after extraction. So when we extract a tooth, it inevitably leads to the resorption, and it has been confirmed by many histological studies and many clinical studies. So clinically, what we can expect after the tooth extraction, that within 6 months, usually there's like about 30 to 60% of horizontal bone loss, and vertical that's like between 10 and 20. As you can see, there are like big differences. They're almost like, twofold. So we should, be aware which are the risk factors and how to spot a patient that is more prone to more resorption after extracted tooth. So the most important thing is the gingival phenotype. Some patients can be thick, some patients can be thin. So if we consider the thickness of a gingival phenotype, is usually also it coincides with the bone phenotype. So usually the patient with thick bone also have the thick gingiva. So when you look at this study that was comparing the, uh, the, the bone loss after extraction, and they try to assess this on the basis of the thickness of the buccal bone at the extraction site in the anterior teeth. So as you can see there, they compared the teeth that have more than 1 millimeter of the thickness of the buccal bone and that have one and less. And they compared by superimposing the scans from before and after healing, 14 weeks, and they compared. So when you look at the data, we can see that in terms of horizontal bone resorption, it could be almost like two times higher in case of phenotype. And in terms of like vertical resorption, it could be almost like 4 times higher. Another thing we should consider is that just the immediate implant placement, it's not going to preserve the bundle bone. Okay, as we said before, we already removed the tooth, so we removed the periodontal ligament, and once we remove the periodontal ligament, that buccal bone wall will be gone. So just placing the implant in the socket is not going to change it. So before we proceed with other treatment options, I would like to present you the extraction socket classification. There's more than one classification, but I believe the most widely used currently is the one that was proposed by Ilian. So according to Ilian, in the class 1 socket, it's actually the most predictable one. It's when we have a intact buccal bone wall and we don't have any soft tissue recession or soft tissue dehiscence. So usually these are the most predictable cases that we extract a tooth and we have intact both bone and soft tissue. In the Ilian class 2, it's when we have a no recession. However, we had some kind of buccal bone loss. Okay, it's not defining how the extension of the buccal bone was, but it should be present. So it's a situation like this. Okay, we extract a tooth, and we can clearly see that there is no buccal bone. You should know we're doing the assessment after the extraction, because even though if we for example, are using CBCT scan before, we can reduce the buccal bone during the extraction. So it can be our iatrogenic procedure that can, change the classification from class 1 to class 2, but we'll talk about tooth extraction a bit more later. And the Ilian class 3, it's when we have a both buccal bone loss and we have a soft tissue recession. So these cases usually can be the most challenging. However, it's still possible to do in many cases the immediate implant placement if you know the proper indications. Diagnosis. So to diagnose the tooth that we are planning to extract and replace with immediate implant, It's what we very often forget. We like starting with a CBCT, but actually one of the best way to make clinical examination is simple probing with a periodontal probe. Not all the bone defects can be seen in a CT scan, and in some patients, especially with thin buccal bone, just the buccal bone cannot be seen in a CT scan. So just by probing, we can get confirmation of our assumption. We can assess the mobility, we can assess pain, that's obvious, and of course, if there are any active periapical infections. From radiological standpoint, CBCT is, I would say, the golden standard for our immediate cases. It gives us a lot of information about the bone dehiscences, about bone fenestrations, about if we have enough bone to anchor our implant. So that's really should be a gold standard when we're considering the immediate implant placement in the aesthetic zone. Should also assess the bone loss and adjacent teeth. If there is, we should remember that thin buccal bone may not always be visible. What I also advise you to do is very useful. At least I'm very happy that I started to doing that in my practice. Is to do a soft tissue CBCT. The problem when you do a standard soft tissue scanning is that you can only assess the bone, but you're not able to assess the soft tissue. When you place like a retractor or ultragate, something to retract the soft tissue, not to touch the ridge, then you can get way more information with that. You can see how far is the gingival margin from the buccal bone. You can assess the thickness of the gingiva. It's very useful not only for immediate implant placement. I use it a lot for clinical crown lengthening. And also, if you find a way for a patient not to touch the palate of the tongue, you can also assess the thickness of the palate and see what is the best site for soft tissue graft harvesting. So it can give you a lot of information if you just do this simple step. Case selection it's crucial when we, as we said, when you want predictability, we need to know which cases are the good candidate for immediate implant placement. So the most common finding that we have in these patients that have class 2 socket is bone dehiscence. So generally, the prognosis depends on the size of the defect. So when it's narrow, means its width, like mesial distal dimension is up to 2 millimeters, it's generally good prognosis. So it doesn't matter how the extension of this defect, right? How big it is in apicocoronal direction. So this is very classical for vertical root fracture. If it's not complicated at early stage with no additional bone loss and inflammation. So if it's just very narrow, it doesn't matter. The prognosis is good. However, the bone defect is wide, so it means it's more than 2 millimeters in the mesial distal direction. The prognosis depends on its apicocoronal extension. So if it's like up to the half of the root, we say, at least in the literature, we can find that it has a good prognosis. However, it is more than half of the root, the prognosis is poor or bad. So I don't mean like, it cannot be done. It's just considered to be less predictable. And as you said, predictability should be our main goal when we are dealing with these high aesthetic anterior cases. So give you an example. This would be a case that would be probably a class 2 socket with the dehiscence that's up to half size of the root, half length. And this is the example with more than 50% of the buccal bone loss. Of this case, it's like more than 100%. It's completely gone. So another factor we have to consider when we are planning immediate replacement is whether we have enough bone to to achieve primary stability and anchor our implant in immediate fashion. So you can see it can vary on a case. Not every case is straightforward. Not every case is easy, and usually we approximate like 4 to 5 millimeter of bone apically for our implant to gain enough primary stability. As you can see now, some cases, even though they look clinically maybe not bad, they are radiologically like very poor candidates because it would be very difficult to achieve good primary stability. One of the most important factors is the periodontal status of adjacent teeth. So I'm not talking about periodontitis cases, but there are some cases with like vertical root fracture or just the inflammation that can cause the attachment loss on adjacent teeth. And these cases are very unpredictable because if we extract a tooth and there's like root exposure, probably bone loss, maybe attachment loss on adjacent tooth, then it can either or not heal. So there is no way to tell because we are not able to assess if there is still any cementum left on that root. And as we know, uh, guided tissue regeneration is less predictable than guided bone regeneration. So in these cases, I'm definitely going for a delayed approach every case. And you should also be aware that this kind of image, like exposed root, could be due to our like iatrogenic extraction. So we should be always very careful when we are extracting teeth and when planning the immediate implant placement. So bone fenestrations, these are the bone defects that are in the apical area. So they're like surrounded with bone with every direction. So usually they are not something to consider because they usually don't affect our aesthetic outcomes. Uh, there can be only like some problems that are very large, and then they would affect our primary stability and our ability to get the right implant anchored. However, the most cases with like periapical lesion, they also have fenestration. So the infection is chronic. There is it's asymptomatic. It's usually not an issue. Talking about periapical infections, so as just said, like chronic infections usually have a good prognosis. We extract a tooth, we remove the granulation tissue, we remove the cyst, whatever the finding is, and that's usually enough. We just place the implant, and it will resolve spontaneously. However, if you have acute infection, it's definitely at least temporary contraindication. If there is like active fistula or even abscess, all right? In this kind of cases, we have to make the infection go a little bit down to get good soft tissue and less bacteria. So in these cases, I usually give some antibiotics 5 days before surgery. And usually, if there is a fistula, usually it's closed after that, and you have a better soft tissue to work with. Now, the gingival recession is a situation in the extraction socket that was class 3 by Ilian. So the management of these cases depends on the height of the gingival recession. And for me, I'm usually doing a tunnel technique to cover the gingival recession simultaneously with the immediate implant placement. So if the recession height is shallow, that is up to 3 millimeters, I find it predictable with the tunneling approach. And if it's more than 3 millimeters, it's usually a delayed approach for me. And of course, periodontitis, it's a different etiology, right? So there are some patients that may approach to you because their central incisor is mobile, but if it's a periodontitis patient, you can extract it too, but don't go, to implant therapy just yet. Causal therapy periodontal therapy is the key, and you should always, start with that, classical periodontal scaling, replaning, and any other surgical therapy if indicated. Usually in this case, bone loss is not really easy to assess because in like active periodontal disease, we're not only having quantitative bone loss, but we also have like qualitative. So we have a bone demineralization that may look like a bone loss is bigger than it's actually there. So that's why even after like non-surgical periodontal therapy, we can see sometimes, we call it a bone gain, but it's not really a bone gain. There is no way to gain a bone with a non-surgical periodontal therapy. It's just bone remineralization. It was a bone that we couldn't see because of the infection. And in these cases, it's always a delayed approach. So just to show you, interesting case because this patient was presented to our office with a mobile incisor and kind of like requested to do immediate, single tooth replacement. And of course, there was no indication for that because of the periodontal disease, but they're so severe that we agreed to the immediate, teeth replacement, but we went for double arch therapy, not single tooth. So, like, there is no way I'm going to place like a single tooth implant, immediate implant in a periodontized patient with no causal therapy. So that's very important. All right. So we know how to plan, how to diagnose our cases. So let's see what are the steps, because steps are always important. Have like a checklist, what to do to achieve a very good outcome. So first and foremost, we tend to forget about this is a traumatic tooth extraction. And as I said before, tooth extraction sometimes we can have class 1 socket, but after our extraction can be class 2 or even class 3. Okay, so we should be very careful. It's not that obvious. Socket debridement, okay, there is any kind of periapical lesions, we should clean that thoroughly. Of course, implant placement, we'll discuss all the detail, all of this in details. Additional regenerative procedures and how to make immediate provisionalization. Okay, it may seem as the least important step, but I would say as a periodontist, not prosthodontist, this is the most important step of all. So starting the extraction, as I said, it has to be the least traumatic it can be. So to achieve that, especially if you have some soft tissue defects or some kind of inflammation, I'm usually starting with this kind of like single-use disposable blades. This is a brand I'm using with a number. I'm not sure if it's like available in your country, but I'm using this, in this kind of, especially with like class 2. When you have a class 2 socket, there is a buccal bone loss. So there's a lot of soft tissue, and while we extract the tooth, we'll be pulling this tissue. So just to be a traumatic, we have to separate this is class 2 socket, all this soft tissue from a root, so that we can extract it in the least traumatic fashion. And we're also doing that on the lingual side. It's a different blade. I'm also using sometimes a bit larger, but there are like many kind of blades that you can use with different companies. Just to show you, okay, how I'm using this, so it's very simple. Most of these blades you can kind of bend. They are like disposable single use, so you can bend them if you need to the proper shape, and just grab the tooth and try to remove it. To extract a tooth, you need good forceps, but even if you have very good forceps, these are the expectations. However, it's not the reality. Like most of my cases, I extract like this, because if they have indications for extractions, they're usually, there's root canal treatment, there is usually some post-core and a crown, so they never, I get extracted so easily. So that's the reality. So what to do? How to extract this in the least traumatic way? So what I recommend you to do is to separate the root in this kind of buccal palatal direction. So I'll just show you in the photos. This is a case we are planning to do immediate implant placement here. We are extracting a tooth. As you can see, there is a post, there's a crown, and it's fractured, so it's very, very typical most cases and like that. So we can take some surgical burr. I'm using a Lindemann burr for that. just to make this separation in the buccal palatal direction, using some small elevator just to separate it. And the goal is to separate this in two parts. And these two parts, let's say like mesial and the distal part, we can then remove separately by elevating this toward the midline, because we just made some space for the elevation. And you should always remember that when we are doing the elevation, okay, we should also be very extremely careful for the papillae, because papillae are, one of the most difficult things to achieve in implant therapy in the aesthetic zone. The buccal side, the buccal thickness, buccal bulk, it's easy. We do a bone graft, the connective tissue graft. I think it's predictable. To get a good papillae, that's the real issue here. So I'm always trying to more elevate from the palatal side, okay, not like between teeth, not on the mesial or distal, just not to make a pressure on the papillae. So usually we first remove some smaller piece, and then we remove the larger piece. Looks like there is no apex, but there was like apical resection in this case. So this is the whole of the root just came out. And just after that, okay, we extract the tooth, the least traumatic fashion. Then we can go to the next step. Okay, we also make debriding the socket. I'm not going to that. You have going into that. You just have to use like some curette. I usually use a Lucas curette just to debride the socket from all the granulation tissue. The next thing is to how to position your implant, and it doesn't really matter whether you're using surgical guides or doing this freehand, okay, as long as the position is good. So you have to know these rules, whether using surgical guides or not, it's not that important. It's just what's important is the final outcome and the final position. I've seen like really terrible implants placed with a guide and placed freehand. So it's not about technique, it's about the surgeon, okay, how he's implementing the right technique. So we usually want to place our implant in a more palatal position. I would say like most cases, the implant in anterior zone is just touching the bone on the palatal side. So in this way, we can get two things. First will be enough space to do our regeneration procedures that I'm going to talk about later. As well, we can have the screw access hole on the cingulum, and that would give us the possibility to perform screw retained crown. I'm not saying there's like something bad with doing a semi-retained crown. The problem is that to make a very good semi-retained crown, it's not that easy. It's way easier to do good screw retained crown, okay? Because you don't have to, make a custom abutment to do all, remove the cement. It's easier. Maybe I'm lazy, but I prefer, to make my life simple and to do the solutions that are very efficient in terms of time. So if we are able to get a screw retained crown, that's always the best option. Still nothing wrong. It can be done very well with the semi-retained. Another dimension is mesial distal dimension. This is like standard value, the number you already know from implant dentistry. This is actually quite easy in terms of immediate implant placement because we're placing the implant inside the socket. It's really difficult to be like to mesial or to distal, so that's more of an issue in terms of like delayed implant placement. And what is, I think, the most important position is the apicocoronal direction. Okay, we need our implant to be deep enough. All right, well, it has a lot of factors. It influences a lot of things, but we need to make sure it's deep. And right now, I believe it should be at least 4 millimeters. The general rule is that the more palatal we place our implant, as I showed you, I place my implants very palatal, the deeper it should be. So I would say it should be like 4 to 5 millimeters. 4 millimeters is minimum. And we need these 4 millimeters for two things. First of all, would be crown emergence. We'll talk about this in the prosthetic part later. And also the implant biologic width. As we know, the term biological width is how we describe different histological tissues that they create a complex that protects our bone implant interface from the oral cavity, right? From the bacteria that are present in the oral cavity and we need enough vertical tissue to accommodate that. So we have a sulcular epithelium, have a junctional epithelium, and connective tissue. So together, all of this tissue, they protect the implant bone interface from the oral cavity. So the implant angle, okay, implant can be placed very deep, can be placed in a very palatal, I would say, according to all that I just told you, but it can be placed at a very wrong angle. So we should remember that our goal is to be placed, at the cingulum, if possible. May not be possible like every single case, but that would be our goal, all right? Like a gold standard. It may not be for every patient, but this is what I'm aiming for every time to get screw return restoration. In some cases, maybe because of anatomy, maybe because of the reed shape, we may end up like this. So general rule, if the screw access hole would be, if we divide the buccal part of the crown into three parts, and it would be in the most coronal third, that's good indication for angulated screw channel or cement retain restoration. So we can do that, ASC or cement retain. And this is still, I would say, acceptable. If we end up in position like this, so the screw access hole will be in like the middle third of the crown, that I would say is like barely acceptable. Like if a patient came to me with implant like that, I would just probably, if it's placed deep enough, it can be restored. It's difficult, but can be restored with cement restoration. However, if I place my implant like immediately, and after I place the implant, I realize like this, I would just remove the implant. Maybe do the delay approach, because usually this position can have some other issues. And of course, if the implant is placed with the axis, that axis hole would be in the apical third, then actually, the prosthetic options for this implant restoration are very limited. And I would seriously consider if it's like a heel implant to remove that implant based just on this angulation. So I'll show you some challenges, so some cases that are referred to me. Let's say this is also a case that was referred to me for assessment, and as you can see, this axis would be probably like in the coronal third. So I would say it can be, do ASC or semi-return restoration. It can be acceptable. Another case, okay, besides soft tissue complication, I did a soft tissue grafting in this case. But if we're to assess only the angulation, that would be probably like in the middle third. So yeah, cement retain restoration can be done. However, if, for example, we're going to fix restoration with this patient, if it was an issue, like aesthetic issue for a place, there was some biological complication, persistent inflammation, it's not much that can be done, okay? Even cement retain restoration, okay? How are you going to screw the abutment, okay? If it's so apical. So this definitely should be removed if you want to get a better outcome. So please remember that, we have to be careful about the implant positioning. All right, so now we'll go into the how to perform the immediate implant placement. As I said, it can be done either with a guide or with freehand. I personally, like most of the cases, I do freehand, but it's maybe because, as I said, maybe I just like time efficiency and planning the guide and printing and checking. It's maybe takes me too much time. However, I see no issues with my freehand placement. So it's definitely like whatever works for you, just stay with it. Okay, whatever works for you or me, as long as the outcome position is good, we can just stay with this. All right, so we are extracting tooth, as I said before, and now we have to make the osteotomy so that the implant position is more playful. So, we're not drilling in the socket because the socket, the previous root position is not the right for the implant position. So I want that to be more played out. So usually I start drilling with like some small drill, thin drill. This is like an initial drill for global decade. And I usually start at the middle or the one third in the apical portion, sorry, not apical, coronal portion, and with this angle that's way more buccal. And after drilling for like 2-3 millimeters, I change the direction. And with that, I'm moving more osteotomy, more parallel toward the palatal. It's not following the socket. That was the first drill. Usually I'm just using, this is the right angle. You see? So the first initial angle is definitely wrong for screw return restoration. However, during the swing motion, during the drilling, it will change. And of course, if you are using surgical guides, it's not that important because you just follow the guides. So that may be simple. So this is the position you want to see. So if we place a periodontal probe between the incisal edges of adjacent teeth, we want to make sure that our angle of the osteotomy, we can use a drill to assess that, is more palatal to that. Then usually I'm using just a drill that's 2.7 in diameter, and that I'm using for the whole of the osteotomy. So the thing is that usually with immediate implant placement, when we are planning to load the implant, which is actually every case, I plan to load every case anterior, we are undersizing the osteotomy to achieve enough primary stability. So the problem is that if we undersize the whole osteotomy length, as you can see here in the coronal portion, there is like on one side there is lots of bone, that's hard bone, and here we have a nothing. We have a socket. So if you place the implant in osteotomy that is undersized in the whole length, you place the implant. We have a pressure here. It can cause the implant to tilt. So with this first drill, with the second drill, like my osteotomy is a perfect angulation. Then I place the implant, and osteotomy is like, it's not so perfect as I thought. Don't ask me how I know. I've been there. So one of the good solutions you can do to fix this problem is I'm usually taking larger drill, like really large drill. Like this is 3.4 drill for 3.5 implant, but I'm only like flaring the coronal part of the osteotomy. So I'm undersizing the apical to get stability, and I'm oversizing the corona not to tilt my implant. So with that, when we place the implant, we get both the good primary stability and we also getting the good axis. So that's very predictable. Then it depends on your system. For Global D, I'm usually using this kind of small bone profiler just to make sure because I'm loading the implant to make sure my abutment is not interfering with the bone. Sometimes, it can prevent you from screwing this correctly. So this is something I like to do. And then we are doing just a prosthetic pickup to make our provisional restoration, replacing the abutment, and we are doing the pickup and provisional restoration. We'll talk about that. So just to show you on the video how it looks, this is like my standard workflow for immediate implant placement. You see we're starting with the angle that's way more buccal, and then we are correcting the osteotomy. So this is just a very small initial drill. I'm not drilling full length, just to get the right angulation to make sure my osteotomy is at the right angle. And then I would just follow with a larger drill. This is 2.4 drill from Global D. It depends on your system, right? Just you to know how I'm using with this particular system. This is 2.7 drill, a very tapered drill, so it's smaller at the apex. And then drilling like 4 millimeters from the zenith of the future crown. So as I said, I want my implant to be placed deep enough. You can check the integration of the osteotomy. As a short drill, I'm just, oversizing the coronal portion of the osteotomy, you see? And now placing the implant. I usually start with the contra angle because it's easier to control the angle. With the wrench, you can change the angle, so you have to be careful. I'm making sure during the final positioning, checking the torque, all right? Checking the depth, is the depth gauge, doing this bone profiler to prevent, the interfering of the bone with the abutment, and I'm placing the abutment, all right? So again, depth gauge, this is very important, okay? So we need to make sure it's one of the most critical aspects of immediate implant position, that the implant is placed deep enough. Immediate loading, all right? So as you said, I'm usually planning to load every case. So I can, make the best, the most acceptable, the most preferred restoration for my patients. And in order to do that, we need to have enough primary stability. We know this from many studies, both from orthopedic surgery and implant dentistry, that if the micromotion threshold between the bone and the implant is more than 50 to 100 microns, then we are not getting to get the osseointegration that's like functional ankylosis. You're going to get fiber integration, like soft tissue encapsulation of the implant, and that would mean clinically just failure of integration of the implant. So in order to do that, it depends on the study. Some studies say you need to have clinically at least 35 Newton centimeters to for the threshold to be below that. Some studies say 40, some studies is 45. I cannot really give you the right answer. Okay, there's no right or wrong. There are different studies on that. I personally using 35, so it's like 35, 40. I'm very comfortable to load my implant. However, I'll show you some techniques like most of my cases like 50, 60, 70, right? So it's very rarely I'm on this borderline. However, I'm still comfortable. It's like 35. It's less than that, I would suggest you to maybe do the delay loading. Another way to assess the primary stability is by using the OSTO, it's frequency analysis, and it's giving you the result of the ISQ unit. So I'm not really using that for like everyday clinically. However, to use that, this ISQ should be above 70. What I like about the OSTO is that you can measure the stability over time. Because when you're placing the implant and just using the torque, all right, so you get like, let's say 50 Newton centimeters today, but you cannot, measure it, after 1 week, 2 weeks, or 3 weeks, because you have to remove the implant. So it's very good for studies. However, for regular clinical practice, I'm not really using that. So, as I said before, when we place our implant in the palatal position, it's just, touching the bone on the palatal side. So that means we're not getting any primary stability here. Even if we try to get some primary stability, as I said, we are risking that, our implant can tilt during the insertion. So all the stability, we are gaining would be from this part. All right, so this is the part that's the apical bone that's the most important for our primary stability. So how to get a good anchorage? Okay, as I said, if the case has lots of bone, there's no problem. However, there are some cases that maybe not a lot of bone, or even maybe a lot of bone, but the bone is like soft, right? It's not a good quality, even though quantity is good. So in this kind of cases, what I'm usually doing is anterior. I'm tending to use a longer implants for that, just to go to the nasal floor, right? If you can get your implant like 1 to 2 millimeters beyond the nasal floor, you can get the bicortical anchorage. Actually, it's not bicortical because it's like there's no second cortical bone, but we tend to call this kind of remote cortical anchorage as bicortical. So If this way, if you're placing your implant, I very rarely have cases, that I cannot load it. So it happens, but it's not common. And as you said, there are some cases you don't have to try. We know that they will fail to get primary stability. So even though this case looks maybe decently clinically, when we assess the radiology, there was there's a bone loss on the buccal that was because of the previous apical resection. There was a placal abscess, so we have a bone loss on two sides. So this is definitely not a good candidate for predictable immediate implant placement. So, and to place implant immediately and achieve enough primary stability, we have to use implants with proper design. So generally, to get more bone-to-implant contact and more primary stability, we can use either the wider implants or longer implants. The thing is that when you're only using the apical bone for anchorage, we cannot really, except going bicortical, there is not much room for going longer. And about the diameter, so usually I'm just trying to use the smallest implant possible. I mean, the smallest, like regular platform. So I'm usually using 3.5 for most of my cases, and then, okay, if I don't get enough torque, I may switch to a larger one. But the smaller implant will give you more room for bone regeneration, so I'm always trying to use the smallest implant. We need aggressive thread, okay, and we need a conical shape. So if your implant's like more cylindrical, less aggressive, it's not the best one for immediate implant placement, and if you want to load the case. Another things to consider, because we are placing the implants very deep, I told you, I mean, not very deep, but it's kind of deep. It's subcrestal. If you're going to make it like 4 millimeters or 5 millimeters from zenith, so we need an implant, a conical connection that can be stable when it's placed, below the bone level, with the implants with platform switching, and we implant with a rough neck. Okay, we don't want any like a polished neck implants to place deep because usually they can cause a bone resorption. All right, so the next topic is a tissue management, but we only have like 3 minutes left, and we have a break and 1.5 hour after break. So we're not going to finish this in 3 minutes. So I'll see you after the break. All right? All right. So see you after break. Thank you.
Và chúng ta sẽ có 30 phút để tea break. Thì sau đó chúng ta quay trở lại với cái phần tiếp theo là cái quản lý mô mềm. Thank you very much.
All right. So see you in 30 minutes.
Yeah, 30 minutes. Right.
Okay, 20. Perfect.